Welcome to UNCG. I'm Aaron Terranova. This is the Master of Science in Athletic Training Education program, and you're about to be a preceptor. So sit back, relax, enjoy the video you're about to watch. Make sure you watch all the modules in our series, and I'll see you at the end of them for your final examination. Good luck. Welcome to the UNCG Entry-Level Masters in Athletic Training Education program, Preceptor Initial Training. The list of modules right now that you've gone through, you should have gone through module 1, 2, and 3, which leads us to module 4, critical teaching strategies. And what we're going to be discussing in this module are some strategies and some hints and tips to better inform your own clinical teaching. And you're going to notice probably a lot of these you're already doing. I'm just going to kind of talk about some other styles that you might not have considered, etc. So the first thing you need to know about teaching and learning is that we typically prefer to teach the way we learn. So if we are a visual learner, we will teach usually visual. If we're verbal, we like to teach verbal. And that's fine, but just understand that your student might not be the same type of learning or teaching style as you are. So you'll have to adapt, and the student will have to adapt to come up to a compromise. Learning styles will depend on the type of skills. Some skills just lend themselves to more hands-on kinesthetic stuff, like doing a Lockman's. Others are maybe done more in a verbal sense, like discussing certain topics, etc. Your teaching strategies will have to adjust and change depending on the type of student you have. A first semester, first year, very green, raw student, well, you'll have to use different teaching styles for them as opposed to a second year, final semester student who'll be seen for the BOC in a few short weeks. And you will appreciate that as these students are on this continuum of learning and developing and maturing, what type of styles you prefer to use for each student. So just a couple teaching styles off the bat, and don't worry about the labels. You're not going to get quizzed on what these labels are, etc. But these are some of the teaching strategies which have been proven effective, especially in clinical settings. Now, I personally love to use the model and the coaching. I think those are probably ones we are most familiar with. The modeling is the I do it, you model my behavior, etc. I think a lot of students prefer this also. Coaching can be used in conjunction with modeling, where you show it, have the student do it, and then you coach them through giving them feedback as they go. Scaffolding is a way to sort of build a base. This works very good for your upper level students where the foundation is already established. They know the foundation, have it be anatomy or basic special tests or basic assessment skills, and you try to scaffold a more in-depth and higher level to get them to higher orders of thinking. Backward chaining, a little bit more complicated. Again, probably going to be used more for your second year students. That's when the last step is demonstrated first, and then they work their way backwards. I like to do backward chaining a lot with my re-evaluations, where the student already knows the injury going into it, but they have to backward chain the assessment to see how we got to where we are. So if they already know it's a torn ACL, backwards do an evaluation and see what should the range of motion testing be, what should all these be based on what you already know the pathology is, etc. And then articulation, this is probably one that some students struggle with. It's the idea of how did you come up with this diagnosis, or how did you come up with your rationale, and they need to be able to articulate it very well. And as a preceptor, you can put as much or a little emphasis on this as you want. I like to use the idea that if you're going to be articulating this to another medical professional or a physician, how would you go about doing it? And this can be both verbal and written. Do not underestimate the ability to use articulation in written format, which is probably a skill that all athletic trainers, including myself, do not do enough of, and we need more help in. So articulation can take both multimedia in various forms. A couple other strategies: reflection. This is where the student actually have them reflect upon their past experiences. This is very good, almost like a pre and post. If you have them get them in the first semester, maybe they tape an ankle in the very first week of their rotation, and then they do it later on in the semester and have them reflect back. How does this compare to the first time you did an ankle taper? How did this assessment compare to the last? And see if they can really be critical. We don't want them to beat themselves up, but reflection takes ability to sort of say, I did these things good, I did these things poorly, here's what I need to do to move forward. Simulations, have the student come up with their own simulations. We have a little bit of downtime in many practices. We get that. So simulations, and I hate to be cynical, but like worst case scenarios work very well. Okay, let's say you're at basketball practice. What happens if? Walk me through this simulation. everything from who makes the phone call, who gets the emergency gear, where does the ambulance go. Walk through that thing. Now, that's an emergency care situation. That's kind of at the top. But you can also do various things. What if someone just goes down with an ankle sprain? What's our protocol? What are we going to do, etc. So walking through those simulations keeps the student engaged, keeps them vigilant, and lets them get more confident if one of those situations actually does occur. And then peer teaching. We do a lot of peer teaching in the classroom. But in a clinical setting, especially if you have a first year and a second year student, that second year can be a wonderful peer resource for that first year student, developing their skills, developing their confidence, etc. So again, all these different types of teaching strategies, don't worry about the label, but see how you can incorporate some of these techniques and strategies into your own clinical teaching. What we have here, though, is Bloom's taxonomy. You probably know a little bit of Bloom's taxonomy. And what Bloom's taxonomy is if you look at the base where knowledge is, these are your basic memorization, spit back, regurgitation type facts. What are the 4 quadricep muscles? And then as you move up to the top, that is the higher level of learning, and that's where you get evaluation. If you look over here to the right, that's where you are judging the value of the material. So you're actually being able to use the material and put an educated judgment on that. And you can see the different verbs that are used. So these are your verbal cues to be asking when you are questioning the student. So if you come back down here to knowledge, you can say, identify the 4 quadricep muscles. Very basic knowledge. Or you can come all the way up here and you can say something like, assess the knee. That means you have to actually judge your special test, your anatomy, your history, your observation, and come up with an actual evaluation. And there are various degrees within Bloom's taxonomy of where we go. And what I like about this is that you can use this in various levels. Most of our first year students are probably going to want to be down here in knowledge and comprehension because they're still just learning these skills. And yes, our second year students should be up here in evaluation and synthesis, but that doesn't mean that you can't ask your second year student basic knowledge questions. And that certainly doesn't mean you can't ask your first year some harder evaluation type questions. So yes, there probably is an increase from first year to second year on taxonomy, but don't be afraid to jump around. Now, when we talk about questioning, please keep in mind that effective questioning is actually planned, clearly phased, and sequential. I know some people love the why questioning. That doesn't work. Research has shown that type of questioning is ineffective. Because if you get stuck in a loop where you're asking why and the student has no idea where you want to go with the why, they get frustrated, they get lost, and it doesn't actually help them. So if you do have an idea that you want the student to end up someplace through questioning, make sure you know how to get them there, okay? And the questioning should be directed towards the situation that is going on and allow the student time to move through. Now, you can go with questioning with Bloom's taxonomy, starting with very basic knowledge, and then as you increase the complexity of the questioning. But it needs to be clear, concise, and clearly phrased. So if you look at this is taking Bloom's taxonomy and including in the questioning. Now, I apologize, this is actually top upside down. So knowledge on the triangle is at the base and evaluation was at the top. So you have to read this upside down. I apologize. But a good knowledge question, what is insulin-dependent diabetes? The latest, very basic knowledge, going all the way up to evaluate each goal. Are they being met? This would be wonderful for, say, a therapeutic exercise. How do you know when to progress someone? Are their goals being met? Because they have to judge and evaluate the current status of the patient and then make a recommendation going forward. So questioning really should be a dialogue, an interaction, and a back and forth between you as the preceptor and the student. I would suggest, again, do not use the classic why type questioning. It's not as effective as people think it is. If you look at the two side to side, so you can see, again, here's Bloom's taxonomy with the type of verbiage being used and the example of questions asked from this study. Hopefully this slide, if nothing else, will give you a nice idea and maybe a starting off point for when you are working with your students in the clinical setting and how you can question them and get the most out of them. Second point I want to make is about feedback. Now, feedback should be clear, specific, and given as soon as possible after the skill has been completed. We already talked earlier about do not do it in front of the patient if at all possible, but once the skill is performed, you've had time to debrief, or this could happen at the end of your rotation. Take the last 5 minutes before you dismiss for the night or for the day, and just say, hey, let's talk about what we did. Give them feedback. Now you have constructive and directive feedback. Corrective feedback confirms or corrects. Directive gives suggestions for how they can improve. Both are good feedback to allow the student to grow and mature. Don't be afraid to utilize both types. Make sure that your feedback is based off an actual observable performance. Do not just come up with non-observable abstract feedback to the student. That means you have to pay attention to what's happening. You can't just give generic feedback. So if you see that they didn't do a skill correctly, make feedback based on the observable skill so the student can then incorporate that and improve. Make sure you compare it to a given standard. So if your standard is that they need to do range of motion for all of their evaluation, and that's the standard you set, make sure the student knows what that standard is so they know how they can compare to it. And always give feedback with the intent to improve. Feedback just for the sake of giving feedback, or feedback that is designed to hurt or knock the student down, is not going to help them improve. There is a time and place for tough love. I understand that, but it should be done always with the intent to improve the student, not to belittle them, or definitely not to make you or the student athlete feel more important. So when you talk about questioning feedback, a couple things that you should keep in mind: keep your questioning concise, keep it directed, and keep your feedback on point to an observable task. Last couple of points that I'm going to be making here are teachable moments. Please take advantage of these. Sometimes they come up few and far between. We know that our students are not allowed to be assessed in the clinical settings on any skill, knowledge, etc. that they have not been tested on in the classroom first. However, if something comes up in the clinical rotation, you don't have to assess the student, but you can still teach them. So even if your student has a lower extremity rotation, and even if they have not had shoulder evaluation yet, if you have an acute shoulder injury, by all means bring your student over and teach them how to go through a shoulder exam. You won't hold them accountable for the information, but they will learn how to do it. Teachable moments can be very rare at sometimes, especially with emergency, general medical, etc. So please make sure you take advantage and tell your student that they are also responsible for seeking out these teachable moments and interacting with you in any way, shape, and form. Last point I want to make about teachable moments: when they come up, understand that mistakes are okay. These are still students. They are still learning, so we are okay with them making a few mistakes. So what have we missed? Just a couple of studies talking about behaviors of good clinical education, helping behavior and standards for preceptors. Just things to keep in mind as you move forward. But hopefully you can use some of these teaching skills, some of these strategies, incorporate them into your own clinical practice. I'm sure many of you already do these type of things, but just keep in mind, especially questioning and feedback, how we can make our students better and how we can hopefully make you a better preceptor. So as we wrap up Module 4, we're coming into our final module. At the end of Module 5, there is going to be a link for you to submit a quick evaluation to verify that you have done all 5 modules of your training. And Module 5 is exactly how we do the nitty-gritty administrative nuts and bolts at UNCG here. So if you have any other questions, you know how to contact me. Again, thank you very much for being a preceptor, and I'll see you in Module 5.